Okay, welcome everybody. Many thanks for joining this afternoon for part two of our webinars, kind of to share with you our latest briefer, Defeating the Double Standard in Diabetes Care. Yesterday, we had a session talking about access to insulin. And today we're going to move on to two of the newer medicines for the management of type 2 diabetes to talk about access to GLP-1s and SGLT-2s. My name is Helen Bygrave. I'm the medical technical advisor on the MSF Access Campaign's chronic disease dossier, which covers diabetes and cardiovascular medicine. So we'll kick off. Just with a little bit of housekeeping, we're going to have three presentations just to set the scene. I'm going to talk a little bit more about these new medicines for type 2 diabetes. I apologize if there are any endocrinologists in the room. I'm a GP and kind of been doing HIV work for the last 20 years, but I just wanted to kind of do a kind of a introduction to these new medicines and what their advantages may or may not be. We're then going to talk about what companies are making them and what they could cost to produce, and then really kind of drill down into some of these key access barriers to both products. Please do introduce yourselves in the chat and write any questions in the chat. We will all try and respond to some of those questions, but also after the presentations, we really welcome you to put your cameras on, join the discussion, and we really want to hear from you to hear your experiences around access to these medicines and what you're seeing in the settings that you are working. So just a little bit of background, kind of the epidemiology. Already in 2024, over 500 million people living with diabetes, and 3 in 4 of adults with diabetes are living in lower middle income countries. 2021, 6.7 million deaths. So this is a huge public health problem and only going to become huger. There's estimates from the Global Burden of Disease studies that by 2050 there could be 1.31 billion people living with diabetes. And as you can see from the graph on the right, this is because of an increase in the number of people living with type 2 diabetes. So the numbers that we are seeing and the numbers our health systems are having to deal with are going to grow exponentially. The other important thing to say is, where are we seeing the biggest increase or the biggest percentage increase in numbers of people living with diabetes? The African continent is seeing the largest rise, followed by the Middle East and North Africa. So this is not only a problem of high-income countries. This is very much, we're going to see these numbers increasing in lower middle-income settings. Just wanted to share this as one example. This was just an article last year about South Africa, the situation in South Africa. And, many of us, certainly in MSF and myself, we've been working, in the HIV world for the last couple of decades or so, and also have had projects in South Africa. But we're really seeing this this epidemiological shift to non-communicable diseases, and diabetes is now the country's leading underlying cause of death in women. Nearly half of people living with diabetes there don't know they've got it, and there are 4.2 million South Africans living with diabetes, with this huge increase in prevalence over the last 10 years or so. So we really going to see these changes in the epidemiology. So I'm now just going to give a little bit of background to the medicines we're talking about today. And I just want to thank Dr. Sylvia Kellenbrook, who's the Director of Global Endocrinology at the Brigham and Women's Health, for many of her slides, which I will confess have stolen with her permission today. So thanks, Sylvia, for all your education on this over the last few months. So type 2 diabetes, traditionally we know that there's an organ in our body called the pancreas that makes a hormone called insulin that helps us manage the glucose, the sugar levels in our blood, that keeps those sugar levels at a good level, that doesn't cause damage. And in diabetes, those sugar levels rise, this hyperglycemia, high glucose, But this picture, why I want to just show this picture is that it's actually a bit more complicated. There are a number of different mechanisms going, involving the liver, the kidney, the gut, the pancreas, even the brain, even, that are contributing to this high sugar in the body. And I want just to keep that in mind, because it's going to be important when we just look quickly at how the GLP-1s are actually working. So if we have persistent high sugars in diabetes, this leads to, over time, organ damage, and it causes damage to the big vessels, which can lead then to heart attacks and stroke, and unfortunately death, and also damage to small vessels, and that can lead to blindness, kidney failure, nerve damage, getting painful nerve damage, and which is very difficult and definitely leads to a reduction in quality of life. And it's important when we say, in the context of the new medicines that we're looking at, that we understand that almost 2/3 of the deaths related to type 2 diabetes are because of problems with the cardiovascular system, strokes, heart attacks, heart failure. So we need to think about how we protect the heart, how we protect those vessels in a better way if we're going to reduce these deaths due to diabetes. So what are we currently doing? So of course we need those lifestyle interventions: diet, exercise, stopping smoking. I'm going to park those for today because we're talking about access to medicines today, okay? But that, I will say, is a given. It's difficult, but is an essential part of diabetes management. So today, in most settings, certainly in LMICs, we start with a tablet called metformin. It can be given between 1 to 3 times a day. If that's not working enough, we add another class of medicines called the sulfonylureas. An example is gliclazide, and it's another daily oral tablet. And then if that is not working, we will add insulin, which is a daily injection and needs cold chain. All medicines have some side effects, some more than others. One of the most common side effects of metformin is kind of gut side effects, so kind of loose stool. And both the gliclazides and the insulins can cause, and in some cases, dangerously low sugars. And they both actually cause you to gain weight. I also just want to point out that at the minute in diabetes, there can be quite a high pill burden, and we don't talk about the use of fixed dose combinations. I think that is something to put on the table. We see that happening and very much being promoted in the management of hypertension, both by inclusion of fixed dose combinations on the EML and in WHO guidelines. So I just want to put that as a food for thought around combining oral medications into single pills as a strategy to reduce the pill burden. So those tools that we're currently using, insulin was discovered over 100 years ago, and the metformin and the sulfonylureas in the 50s. So since then, since the 50s, there have been a whole host of new diabetes medicines coming through the market. And what happened in 2008, because of this recognition that most people with diabetes are actually dying because of complications in the cardiovascular system, the FDA said, for any new diabetes medicine now coming on the market, we want to know what is its impact on reducing deaths from cardiovascular disease. They put this as a demand for anybody producing a new diabetes drug. So the 2 diabetes drugs that have really kind of risen out of this in the last, I'm going to say last decade, are the sodium glucose transporter inhibitors, sorry, horrible long names, the SGLT-2s, and they're the gliflozones. So you'll hear empagliflozin, dapagliflozin, canagliflozin. And then secondly, the glucagon-like peptide receptor agonists, so the GLP-1s. Now, these were initially licensed for diabetes, and there's semaglutide. You might have heard of Ozempic from Novo, dulaglutide, which is Trulicity from Lilly, and there's another one, tirzepatide, which is actually it's not just the GLP-1. I won't go into that, from Lilly. But these drugs have also been shown to reduce to support weight loss, and so some of them have also been licensed for obesity. So semaglutide for diabetes and semaglutide for obesity, they are exactly the same drug, but at different doses and given different trade names. So Ozempic is for diabetes, Wegovy is for obesity. So just going to very simply say, how are these drugs working? In summary, the SGLT2s, I say they're oral tablets taken once a day. They make us pee the sugar out, okay? So they stop our kidneys reabsorbing sugar. And this is why the most common side effect we see with these drugs are getting urinary tract infections and kind of genital thrush in some cases. And then to say, and they say there's, this is just as an example, is that there is clear evidence across the glyphosins that these drugs reduce the risk of cardiac death. The GLP-1s, these are once weekly injections. They do require cold chain prior to use, but the good thing is unlike insulin, you don't need to be doing self-glucose monitoring. So that's a bit of a cost saving to think about if they're introduced as a step before insulin. And the other thing to say is that we know in the pipeline there are better oral products on the way. And coming back to that picture I showed you right at the beginning, these GLP-1s really are acting via multiple mechanisms, yeah? Hence why I think we start to see them being promoted and potentially being used for other indications as well. And again, I say I just picked this one trial, which was liraglutide, which is actually one of the first GLP-1s to be developed by Novo Nordisk. Again, there's now clear evidence around their benefit in terms of reduction in cardiovascular events. Also, and importantly in diabetes, these drugs, the GLP-1s, help us to lose weight, and semaglutide has been demonstrated as the one that does that most effectively at the moment. So in the pipeline, there is a huge pipeline of GLP-1s, both from Novo Nordisk and Eli Lilly. Some of them are small molecules, some of them are oral. But this market, and I say particularly looking at the market of obesity, and we'll look at that in a second, these companies, are kind of investing hugely in the development of these products. But I think the important thing is there are some oral options coming, which may be easier to use in lower middle income settings. So coming back to the drugs we're using now, and we look just on the left-hand side of this diagram, the impact on lowering sugar. So that's the HbA1c, is how we measure the sugar in the blood over a period of time. You'll see that metformin kind of sits in the middle of the diabetes medicines, sulfonylureas a bit lower down. Insulin is obviously better, but the GLP-1s come out top. And when we look at body weight, as I said at the beginning, metformin kind of just under the middle, but insulins and sulfonylureas really kind of, again, we do see weight gain with these agents. So just to summarize, the SGLT2s are a daily oral tablet. Don't need cold chain, don't need monitoring. Generics are coming very soon. They are on the WHO EML, but they're not in WHO global normative guidance. GLP-1s are a weekly injectable, do need cold chain prior to use, doesn't need monitoring, definite interest from generics, but not there yet. And they are not on the EML or in WHO guidance yet. And so, as I said, what we're seeing in high income settings in the US and Europe is this shift away from managing diabetes, just thinking about, am I controlling your sugar? We've really seen this kind of paradigm shift of how we think about the management of diabetes. So yes, we want to control your sugar, but we also want you to lose weight, and we want to use agents, we want to use medicines that reduce your risk of death and morbidity from cardiac problems, and protect the heart and protect the kidney. And we now see in the US and EU guidelines that these two products are actually moved right to the top of the algorithm to be used as first line. I do want to flag this dual indication for GLP-1s. Yeah, so as I said right at the beginning, we already have 500 million people living with diabetes who potentially could benefit from these medicines. But we also have, already billions of people, and estimated in the next kind of 10 years to be up to 4 billion people globally living with obesity. So I think part of our debate today is, with the limited supply, because there are no generics, because these drugs are under patent, how are they being used within public health principles versus profit principles? Plus, and we want just to say also, these are being made by the same companies that make insulin. And so what is those companies' responsibility for ongoing supply of insulin, which is essential for type 1 diabetes and will still be needed by some with type 2 diabetes, also across the different presentations in vials and pens, which are preferred by many. So this is a situation we're in. These medicines, GLP-1s, being hugely advertised and promoted for the management of obesity. I would say the marketing strategies and private sector on this is out of control. Meanwhile, people living with diabetes, even in high income settings, are being swapped around or cannot get access to their prescription. And nobody in any public health sector in low and middle income country has access to these drugs or SGLT-2s. So I'm going to hand over now to my colleague Krista, who's going to look more at who's making these drugs and what their costs could be.
Okay, great. Thanks, Helen. Hi, everyone. I'm Krista. I'm a pharmacist working at the Access Campaign together with Helen and Lena, our colleague who's going to go next. So next slide, please, Helen. So these, just to review what companies we're talking about, who's making these medicines that Helen has just described. The GLP-1s are made by very familiar names, Novo Nordisk and Eli Lilly, who of course we talked a lot about yesterday in the insulin seminar, if you were there, as the two major manufacturers of the more leading GLP-1s today. Next slide. And for the SGLT-2s, they're different companies, although you see Eli Lilly there for EMPA. These are AstraZeneca, MSD, and then a less familiar pharmaceutical company to most of us, relative to the big pharma names that we all know, for Canna. Okay, next slide, please. So again, this is just to reiterate the kind of, size of the market, or who are these people who are in need of these medicines. And this is just to reiterate the huge numbers that Helen also just reviewed. In the obesity market, in 10 years, it's going to be 4 billion people. And for type 2 diabetes, it'll be over 600 million people by 2030. Next slide, please. And so those numbers, again, we saw this slide yesterday, that insulin is still dominated by these three corporations, which are just enormous, making just eye-watering profits, expanding all over the place, making new manufacturing sites, and making huge returns on earnings per share. Next slide. But they'll look familiar to you when we consider them. They're also the leaders in the GLP-1 markets. So sorry for Sanofi, he's got a yellow mark over his face, but the other two are the CEOs of Novo Nordisk and Eli Lilly. And obviously you can't see this, but these are the kind of profit earnings that you can see in their annual reports, with everything just going up. Everything is positive, double digits everywhere, growth and profits and expansion, etc. And we know that Eli Lilly is on track to become $1 trillion company in the coming years, and that Novo has become the biggest company in Europe, not the biggest pharmaceutical company, but the biggest company in Europe, really driving the GDP of its host country, Denmark. Next slide. Yeah, all around the profits of those GLP-1s. No, it's okay. It's just more, yeah. So this is just more on the profits and the growth and the projections of these companies by 2030, making a profit of over $100 billion, which is just, yeah, incredible when you think about return on investment. Next slide, Helen. So we want to think about how these companies price their medicines. And so we went down the path of trying to estimate how much they could cost to produce. And this is a kind of methodology that has been used with other essential medicines for TB, all of the medicines on the essential medicines list, for example, medicines for hepatitis C. It was done by High and Axis for insulin some years ago, and this is updated cost of production data that Helen presented yesterday for insulins. But we also included estimated cost-based prices for these medicines, SGLT-2s and GLP-1s. Next slide. So this is not to be digested, but you can look at the methodology that's in the paper, in the JAMA paper, but it just shows the methodology that is used to consider all the inputs into the manufacturing process, adding a conservative or a conservative or a competitive profit margin of 10 or 50%, and then all of the other inputs of API, manufacturing, tax, regulatory, etc. Next slide, please. So this is the left-hand column is the estimated cost-based price of what these medicines could cost per person per month. And the right-hand column is the lowest market price per month, based on a survey of publicly available price databases in 13 countries, and mostly middle-income and high-income countries, because we don't have access to any publicly available price database for a low-income country. And maybe the one most of interest that everybody thinks about is semaglutide, injectable once a week. What prices that you'll find on the market is anywhere between $38 to $351 per person per month, whereas the estimated cost-based price, the estimated cost of production, runs less than $1 per person per month, up to just under $5. So you can see the enormous profit margins that these manufacturers are making. And for the this is just in a graph form, so you can see these are the different countries where we had prices. The US is obviously off the charts, very high, injectable, semaglutide, and the oral, down to the estimated cost-based price on the right-hand side, and then some of the other countries, South Africa, Brazil, Bangladesh, etc. For the SGLT2s, again, the cost-based price per person per month can be as low as just over $1 with DAPA, whereas you see the market price per month based on the publicly available price databases runs between almost $4 to over $526, again in the US. So these are just enormous markups on top of the estimated cost-based price. Next slide, please. So I've just thrown that in there. You can see in the paper all of the estimated cost-based prices per person per month compared to market prices. Next slide. So what did we do about that? We released a briefer last week that I think we've mentioned quite a few times, and you've seen it's available on our website. And we tried to show in graphic form the kind of markups that we see for these medicines, for the SGLT2s and the GLP-1s. And in some countries, for example, in the US, for DAPA, you have 40,000% markup on top of the estimated cost-based price. And I mean, all of those percent markups are quite eye-watering as well. So we looked at, for example, in Brazil, in India, etc. Next slide, please. There was quite a bit of media pickup, and it became a kind of hot topic of the day. We have media in India. It got quite a bit of pickup in India because of the enormous prices and lack of availability of these medicines in most health facilities in India. Okay, and as well, there was a front page of The Guardian as well. Next slide. And as well, this is my last slide, what's happening in the US is that Bernie Sanders picked up this publication and has really gone to task on Novo Nordisk, has written an op-ed in a Danish newspaper, a political newspaper. He wants to meet Novo Nordisk's CEO on Ozempic pricing in the US, and is being very supportive of the kind of global issues that we're talking about. Because it's not just about the fact that these medicines are very expensive, and the fact that they're not available, even though they're highly recommended in high-income country settings, as Helen reviewed the guidance. They're not available in public health sectors, but nor are these companies interested at all in making them available currently. They have no access plans. When we talk to these companies about availability of these medicines for people with type 2 diabetes in low and middle income countries, they don't have a plan. They don't have any kind of outside of kind of small supply through the private sector, they don't have any access plans or plans to scale up availability. And they have a duty to supply medicines. And as we see more and more manufacturing done of these injectable medicines, like semaglutide in a pen, we're finding more struggle with having availability of insulin, both in vials, but also in pens. Not confirmed why, but the kind of, the suspicion is that a lot of the manufacturing capacity of these same two companies who are making insulin is going more into the GLP-1 manufacturing lines. And we're struggling with availability of insulin in some markets now. So with that, I'm going to hand over to Lena. You can introduce yourself.
Yeah. So good afternoon, and I just wanted to say that building on what Helen and Krista here have added, I just wanted to highlight a couple of things that have gone through my mind when I attended an excellent conference last week, which looked at humanitarian crisis and diabetes, and IDA organized it. And if you don't know the organization and you're interested in diabetes, do look it up. I just wanted to highlight something that at this conference that came up, three things that came up in my mind, that we need to think of diabetes in humanitarian crisis. And, you've got a world where in Gaza to Ukraine to Myanmar, you've got people with chronic diseases like diabetes who've been deprived of treatment, including the insulin that they need. Number two is this, that there is a massive disparity between the way diabetes is being treated in high-income country, for example, with insulin pens, analog insulin pens, and now, of course, with the new, with the oral medicines that we are seeing, which are not exactly new because and I'll go over that. And we need to do something to pump start our health system. And that's where I wanted to highlight in this slide that what can we do to get a public health system to start making these newer medicines available to us. Actually, they're not new, but nevertheless available to us. The first thing, of course, is to look at guidelines and EMLs. And of course, the WHO EML covers SGLT-2s, but not specifically the way we would want to in terms of guidelines. So we need some work over there. We've got GLP-1, not included in the WHO EML. And what we would like to do is work with civil society across the globe, particularly low and middle income countries, with the people who want to put in a submission for diabetes. So we need support from LMIC organization and people living with diabetes to support the submission for the AML inclusion of GLP-1. And I think this is a very crucial step to arguing for greater access in our countries. We've got to lower prices with generic competition, and I'll come to that. And of course, we've got the targets going now, which is fantastic because we've seen that work for HIV, which is that you have targets for screening, you've got targets for interventions, and I think you can look at the targets that have come out of the World Health Assembly resolution for member states. You can also look at the South Africa targets, which I was quite amazed at, that the South Africans had put those targets very specifically and were working towards achieving them. So I just wanted to highlight these major developments that could help us increase access for the most poor and marginalized who can't afford treatment in the private sector. So next slide. So a lot of us who are familiar with it, but there are a lot of us on this call who may not be familiar with it. We know that how monopolies work in our own countries. For example, in India, right now, semaglutide, you have a patent on it. The generic companies can't make the pens, and Novo is only offering the oral drug. So they work the patent, they have the monopoly, they set the prices, they also decide which version of the drug we get In our case in India, we've not got the pens, we've only got the oral drug, which has poorer bioavailability. So the monopolies are blocking our access, and they are driving up prices in high income countries for sure. But in our own countries, often these patent monopolies are either making those medicines very expensive or not providing access at all because the patent has not been worked. So next slide. So what do pharma corporations do? And I really need to adapt this with a comms team to diabetes. They take a particular class of drug, a drug that's already been patented once, and then patent it in different ways. It can be a combination, but it can also be in a device, in different devices, and try and evergreen it, as we call. That means you extend the length of the monopoly by using the follow-on patent claims that exist. And I just wanted to simply say that we are on the cusp of some good news, but we really as civil society need to come together about doing some work around intellectual property. Next slide. And I also wanted to highlight this, that both these drugs that we are talking about, SGLT-2s and GLP-1s, there isn't a situation where we will need tech transfer. So what we really need to do is to look at the barriers that prevent the scale up of generic competition. So this is really a very important point that we really need to remember. So SGLT2 going off patent, in the background in India, while we were not even aware of the importance of these drugs, there's already an IP battle brewing. So for the glyphosins, DAPA, for example, the Indian companies actually launched it in 2020. And they did it right after the expiry of the Marcouche claim. And then the matter went to court. The company, the patentee tried to block it. The courts did not grant the injunction, and DAPA continued in the market. And of course, more recently in 2023, the secondary patents have started to expire, and that has made DAPA available. We have the same situation, for example, on the glyphosine that's about to expire in 2025. Unfortunately, it was launched but withdrawn. No public interest group actually intervened because we just didn't know that SGLT2s were so important for diabetes. So yes, we've got this coming. And of course, the crystalline form, for example, may extend the monopoly in South Africa. So these are things that we need to be cognizant of. Next slide. Yes. So for us, we are looking at Ozempic semaglutide, which is the generic version would be, we don't know the brand name, but generics are there's going to be a pipeline of generics. But it is up to us to look at what's the situation on evergreening is. That means you have secondary patent claims coming in after the expiry of the basic patent. And of course, question, will device patents block access? And this is something, can the generics beat the device patents with their own devices, or we are going to be stuck with Novo and other companies blocking access to the semaglutide pens? So we really need to know what's the freedom to operate in our countries, both in manufacturing countries and supply in low and middle income countries. We need answers because we're going to need to scale up these drugs. Next step. So this is just a snapshot of one generic company's report that I found. And of course, you can see it has the drug in its pipeline. They're obviously developing it for the US market, but of course, the benefit of that is that the drug is available, it's already produced, it's waiting for us and all of us to come up with a strategy to get it into our countries. Next. And we can't forget the oral drugs. We did it for Hep C. And this is something that we really need to start working on. We need to look at there's orforglipron, you've got tirzepatide and retatrutide. I really have to mug this up, but I just wanted to simply say this, that if we don't intervene as civil society, we've got very lengthy monopolies on these drugs. We don't know which one is going to be the most effective. So keeping an eye with Helen and Sylvia and others on what the evidence from clinical trials is, and as civil society, picking our battles on intellectual property, as I would say. Next slide. So what is our recommendation? Greater attention from civil society and governments to the patenting practices of pharmaceutical corporations and the resulting lack of competition, availability, and affordability of diabetes medicines is essential to increasing access for people. And I think this is absolutely crucial that we take the message back, do local meetings within our own communities in India, South Africa, Thailand, Brazil, and all the places where civil society is very, very, very active. I think the medicines patent pool will seek voluntary licenses. It's a no-brainer. They're going to go and try and get those. We also need to remember that there are countries who often left out of the access algorithm, which is basically they're not included in the voluntary licenses, and we need to start thinking very clearly about how we're going to do the compulsory licenses, because we can't afford to leave anyone behind in terms of access for these drugs. We're going to see an exponential need for those drugs, and we've got to have parallel track strategies, as I would say, for countries like Colombia, for example, who just issued the compulsory license for DTG. They were not part of the voluntary license, and therefore, it's come a decade late. So we need to think about compulsory licensing and voluntary licensing in parallel tracks. They need to go together. Next slide. So I just wanted to do a bit of digging around the Novo Foundation, because you come across this company, Novo Nordisk Foundation, often. Now, Novo Holding is the investment arm of Novo Nordisk Foundation, and that has 77% control in Novo Nordisk. And if you look at it, they're becoming the largest donor. They actually fund infectious disease. So the irony is they're getting all this profit from the diabetes market and actually starting to donate some of this to the WHO, to working on different areas of public health, and actually very little is being done about holding them accountable for actually where they're getting their profits from. And of course, the WHO's been a little tone deaf out here. So if you look at it, even as the US Senate committee opens investigation into Ozempic, and all the coverage about shortages in the NHS, you've got the WHO Director General's remarks on Global Science Summit. He says, "I congratulate the foundation on its 100th birthday and for everything it has achieved in the past century. When we've not done very well on insulin pens recently in South Africa, for example, we very much appreciate your support for WHO and for the global health more broadly." And I think this whole area requires much more accountability from pharma corporations. They've dominated insulin. Then you're going to come in and use some of those same strategies for GLP-1s. And we've really got to be very cautious about how we build a campaign for increasing access to diabetes drugs. And of course, Novo Nordisk Foundation should be at the heart of that campaign, because they're deriving their profits and then trying to donate it. So I think this is something that we really need to be cognizant of as we mount and look at intellectual property challenges to this, as I would say, empire that these companies have built around diabetes. So I'll just stop here if there's anything else. We have the access campaign plans in the next 6 months. We got the bilateral letters and negotiations with the big three requesting pricing strategies to reflecting cost of production for SGLT2 and GLP-1s. Of course, for SGLT2, we'll also look for generic sources and quality assurance. Dependent on response, public letters and communication, briefing and engagement with diabetes and access to medicine civil society, particularly human rights lawyers, I think, who have been absolutely brilliant at HIV, Hep C, and all the legal aid they have provided at competition commissions, in courts, in patent offices, and of course, that partnership is very valuable between civil society, patient groups, and of course, human rights lawyers. I hope quite a few of you can keep in touch with us. So when the work starts on the submission to AML for GLP-1s, we can support that at the time when it is developed. And of course, we can go into more in-depth access issues in country, whether they have been registered, what's the pricing, and whether inclusion of diabetes drugs and monitoring tools and national guidelines, public health systems, and of course, insurance schemes. So I'll stop here and open the floor for Yeah. Yes. So I just wanted to say, since we are all across the world, if you can put on your video and put up your hands if you have questions or just comments, we'll be very pleased to have that while I look at the chat and try and moderate this. Yeah. We haven't had any hands up. Oh, we have Felix. Go ahead, Felix.
Hi, morning everyone. Thanks so much for the interesting presentation. I have a question regarding the EML application for GLP-1s. How likely do you think is that one to succeed, given the still very high prices of GLP-1s?
Okay, so I'm going to hand that over to Helen over here, but I just wanted to say it's a chicken and egg. I think the WHO should put it on the EML so we can fight to lower prices, not the other way around. So over to you, Helen.
Yeah, Lena, you took the words out of my mind, out of my mouth, Felix, because the EML has been, in a way, a tool for advocacy. You know, we didn't stop putting the HCV drugs on there just because they were costing 40,000. And if you look at the number of cancer drugs that have just been added to the EML, which have some crazy prices, and I think the EML folks at WHO actually see that. They see it as an advocacy tool. How hopeful are we of its success from a clinical medical point of view? I think we're hopeful. I'm going to say I don't want to kind of jinx us. I think we're fairly hopeful. What I'm going to say, I think where the nuance is, Felix, at the moment, there is neither any WHO guidance for the use of these drugs for diabetes nor for obesity. But there may actually be a technical guidance coming for obesity before diabetes. And I think the nuance for the committee is going to be for diabetes, for obesity, and or how do governments then prioritize their use? And this is what we're seeing and why today we're talking about GLP-1s in the context of diabetes management, 100% recognizing their role in the management of obesity. But with this limited supply at the minute, you know, how do we use them so they have the most impact for the most at risk? So I think for the EML submission, that is going to be probably the point of debate in terms of indication for diabetes and indication for obesity and how they maneuver that in the lack of WHO clinical guidance. Yeah.
Yes. And that's fantastic. So, you know, WHO should be the starting point of, you know, addressing the double standards between high and low and middle income countries. So, Alison, over to you for your query. If you want to switch on your camera and, you know, or just verbalize your query.
Hi, everyone. Thank you so much. This is Allie Bancroft from HealthGap. I use she, her pronouns. Excellent presentation and discussion. Thank you so much. I would say I have more of a comment, and forgive me because some of this information might seem pretty obvious to a lot of you on the line, but I do want to reiterate that I think one of our big challenges in this work will be the stigma facing type 2 diabetes. And I think that there is inappropriately and incorrectly a lot of blame for patients living with type 2, even sometimes among really educated people or even clinical professionals. And so I think that's something that we're going to need to take into account with all of our work, you know, almost a re-education and emphasizing the message that absolutely everyone, everywhere, you know, regardless of what their diagnosis is deserving of access to medicines. And so just, I know that diabetes is not unique in that way, but I think that we see such a challenge with it. And for background, I've had type 1 for a very long time. So I think I'm also very aware of how some people with diabetes can be unhelpful in this way. And actually, I can throw a book recommendation in the chat that talks about how like race and power and all sorts of other social factors influence the way we classify diabetes and treat it. So thank you.
Alison, I was just thinking, you just took the words out of my mouth. I think we need to build a track on diabetes, on diabetes and human rights, addressing issues relating to stigma, discrimination, and of course, sometimes it's a double whammy if you are HIV positive and you've got type 2 diabetes. We are seeing double burdens come across, and people face those double stigma and discrimination. And of course, we need to address not just the access to medicines part, but of course the larger issue of what we are seeing, for example, in India, children with diabetes not being admitted into school or not being allowed to attend school. So tremendous space for human rights work, I have to say, in diabetes. And that, I think, is what motivates me to start working on diabetes there. So anybody else who wants to put up their hand? Thanks, Alison. And we can sort of perhaps organize something together on HIV and diabetes, because there's some work being done in South Africa. I think we can come together in the HIV movement to talk about this as well. Very happy to collaborate with HealthCap on that. Anybody else? So yeah, Peter, go ahead.
Hi, thanks for the excellent presentation. Great to see you guys. Lena, you referenced this a bit, but I missed part of it on the generics landscape right now. To the extent we can overcome patent barriers, how quickly are we positioned to bring competitive alternatives online globally? What insights you guys have about that? Thanks.
Okay, so I just wanted to say something. If you look at GLP-1s, which is where we are looking at, the generics recognize that there's a demand for this, and they're building. Every single mid and big size company in India is building, who's in NCDs, particularly in diabetes, is already way ahead in development. APIs have already been produced. I just also wanted to say this, that it's because it's not a biological drug. The fact is that anybody who has an injectable facility, and many of them do exist, which are even US FDA approved or WHO pre-qualified, we've got a very strong possibility of having a generic if we address the barriers. The barriers could be regulatory also, and we could have a separate discussion on that. But I also wanted to sort of highlight is that we don't, as a community, understand how patent devices are actually enforced. And we may have to muck around in them, in the sense that, you have companies who go to court to enforce the device patents, and we have to intervene and ask the courts, please don't enforce the device patents, in the sense that do not give injunction orders to shut down supply of the first generation of GLP-1, which is semaglutide pens. So I think this is happening as we speak, and I wouldn't be surprised if the Egyptians have got up to it, the Chinese, of course. Would not be surprised if Bangladesh was already into it as well. So you can already see that there's a lot of work going on behind the scenes with the generics. And I just pulled out one report which I had put up, which clearly shows that companies want to be the first generic in the US. So they've started that work. They filed the ANDA filing, and you can pull that information out, Peter, to see who actually is sitting there on the pipeline from the generics.
Thanks. Let's talk about those regulatory and device barriers when we can. Thanks for your work. Good to see you guys.
Yes. So just anybody else who has a question? Yeah, Esteban.
Yes, hello. It is Esteban Borone from the Medicines Patent Pool. I had a question about, so when you were showing, I think it was Helen, you were showing some of the various different options that exist, of course, for type 2 diabetes treatment, the ones that are being used, and also the kind of prices that, many of them have, the sulfonylureas and some of the earlier ones, but also SGLT-2s, potentially, as these are relatively simple small molecules, oral tablet formulations, etc. So in that kind of context where you might see GLP-1s coming down the road in low and middle income countries, they would of course get into a marketplace where there are other options there. And so what do you think are what do you think would make sense in terms of initial early adopters? Who would be the kind of populations that one would think could particularly benefit from this and would be the place to start if one is really thinking about how this could gradually be introduced, bearing in mind that to start off with, regardless of who actually brings it to market and whether generics come in at any point, initially at least will likely be more expensive, particularly in thinking about the GLP-1s, will likely be more expensive. They're more complex molecules, etc. And so I'm just trying to I'd be interested in hearing your thoughts in terms of how do you see adoption taking place?
Yeah.
And if there are groups that would be obvious first targets.
Yeah, absolutely. And Sylvia, I know, is online, so please, Sylvia, chip in. So look, I work in the NHS. My first head of mission said, I really like you guys because you're used to working in a resource poor setting. So our algorithm in the UK actually is not quite as they're not putting them as first line. So even in the UK, so to answer to your question, it's about identifying those most at risk. So people living with diabetes who've already got some underlying cardiovascular problems, who've already got evidence of kidney problems. Yeah. Okay, so for the SGLT2s, it's clear for me that if you've got any of that as a subgroup in your diabetics, they're the ones who are going to benefit the most. Likewise, to be honest with you, now we've got so much evidence coming through on GLP-1s and their benefits in terms of cardiovascular benefit, even if you don't have diabetes. I think for both these drugs, it's about identifying within your diabetic population those most at risk. However, I'm going to caveat that, Esteban, with that is not always easy. I mean, okay, I'm not talking about South Africa. In a lower middle income country, having the diagnostics to identify those groups is not always easy, yeah? So I hear your point around, obviously, this has got to be cost-driven within an algorithm, yeah? So do we start with metformin, add an SGLT2 to select groups, yes? And then bring GLP-1s in for those who are overweight, and people who are not overweight still get insulin. But when I start to see those algorithms, because we've been drawing those algorithms in MSF, Esteban, to try and work out how to introduce these products, bearing in mind the cost. And I always become very nervous when our algorithms have too many bifurcations in them. Yeah. It just doesn't get implemented in our settings, and I think even in the UK, yeah, and we see the success that we've just seen with hypertension. I think there's real movement in hypertension with the work that Resolve is doing, the new WHO guideline, where we've got a simplified algorithm, yeah, and it's clear that everybody gets the same thing: step 1, step 2, step 3. So I think there's opportunities with the oral molecules. I think realistically, Esteban, where countries will start is metformin plus SGLT2s. And I think whether we bring the SGLT2s just for people with underlying cardiac disease / renal disease first might be a question. I'd also like to we looked at fixed dose combinations for hypertension, and it was always cheaper to make the fixed dose combination than the sum of the two parts. And I do think we're probably not so far off. If we looked at metformin SGLT2s, what would be the cost of those fixed dose combinations to, again, simplify the algorithm? Yeah, okay. So I don't know if I've answered your question at all there. But in the UK at the minute, it's metformin, SGLT2s if you've got underlying heart problems, kidney problems, and GLP-1s are definitely third step at the minute in UK guidance. Yeah.
Yeah.
Because of cost.
We've got the simultaneous track of simplifying and working on
it.
The same
I think there's real work to be done in diabetes on that simplification of doses, number of pills, steps in the algorithm. Yeah.
Yeah. So I know that Okoro has been waiting. So I just wanted to ask Sylvia if you want to add something at this point. You're welcome to do that. Some fantastic presentations in IDA. So if you have a comment over here, yeah.
Yeah, no, thank you so much. I think Helen covered it all. I would say the obvious people you would first allocate these new drugs to are people that with established cardiovascular risk, established, if they have heart failure, renal failure, as Helen was saying. The one thing I will mention is that the GLP-1s have had significant stroke risk reduction. They're mostly anti-atherogenic, which the SGLT-2s did not show. So for me, if I have a patient with a history of stroke or carotid stenosis or whatever, I will immediately think of the GLP-1 agonists because we haven't seen that with any other drug the same way. So I just wanted to mention that one distinguishing factor. Thanks.
Yeah,
Thanks,
thank you
Sylvia.
so much. And I think this is a very big challenge, but let's see what happens on the simplification, and a lot depends upon the pipeline and what we have in terms of the products that is there. I just wanted to say someone wants a recording for yesterday's webinar. We'll try and do that, but I just wanted to hand over to the person who put up their hand, and I'm just looking for that hand, and I haven't seen
Okay,
it.
I'm here.
Oh,
Hi.
go ahead. Yes, please. Go ahead.
Okay, my name is Nkirika Okoro. So I've lived with type 1 diabetes for 36 years now. So just a quick question with regards to the GLP-1 agonists. What is the long-term effect on the beta cells, seeming that these drugs tend to stimulate the cells to produce insulin to control blood sugar levels? So in the long term, has anything been looked at? Like, would there be a reduction in the beta cell count over a period of time, or it has no effect? That's just my question.
Sylvia, I'd not to put you on the spot. We're really abusing you today. Are you able to help me with that one?
Sorry, I was just answering Esteban's question in the chat. Can you summarize one more time the question?
I think, Nico, it's the effect on the beta cells in the long term, yeah?
Yes.
I'm not aware of data on it preserving the beta cell per se. They do help secrete insulin. They help you make insulin and reduce glucagon production. Whether or not, maybe, it's not like the most obvious data that I've seen, so I'm not aware of that, but they will often delay, like the GLP-1s will often delay the need for insulin because, obesity itself drives insulin resistance and diabetes. So if you can lower the weight and help with insulin secretion, it will put off or even help people stop insulin. But whether or not, to what extent it preserves the beta cell, I'm not sure.
So
Thank you.
yeah, I know that we are almost to the hour, as Helen would say it. So if there's any last question, but I just wanted to say is this, that if we don't drive the access agenda from a public health point of view in the public system, we are driving patients into the hands of the private sector. And I come from India, and I know what happens to patients when they go to the private sector. So I just want to say this, that these drugs will be used very widely in the private sector. Diabetes is one of those diseases where a large number of patients actually get treated in the private sector. We really do need simplification. We need access in the public health system, and we need to start thinking of providing better treatments in the health system. So I just wanted to say this, that it's not as if these drugs will not be used in our country. They are likely to be used, but only available to people who have high incomes in our country. So just sort of highlighting that. So if anyone has any more comments. Oh, there's a question in the chat. Yes. So Ramya has put this question. I know Ramya very well. She does some fantastic work on patent challenges. She contributed to the Bedaquiline patent challenge. India with the highest number of diabetic patients. Why are Indians not capitalizing on it apart from patent merit? Is it to do with regulatory approvals and lack of government interest in the issue. So I just wanted to say this, Ramya, that the Indian companies are working on GLP-1s. They've got a previous generation liraglutide out in the market. I think the challenge is with semaglutide pen, which is still, the compound is still to expire, active substance is still to expire. We'll see the availability. And I think what is unfortunately in India, as with insulin, very few states actually offer the pen. We are seeing that a large number of patients are simply treated with the older 1950s drugs. So if you want to work on access together in India, we need to start talking to government at the same time about improving what's available in the health system. So yeah, tenders in the government system can drive manufacturing and availability of generics as well. And yeah, so I hope, Ramya, I helped answer that question, but if anyone else wants to contribute from the panel, I'll be happy to step back on that. Yeah. Okay, so that's it for today. And for all of you, this is the first time we're presenting a lot of this work in a more public forum. So please be in touch. And I hope we can organize more sessions with the, different affected communities, but also I hope Peter, Public Citizen, will give us some space in the COVID list so that we can organize another session on this for people who missed it. Yes. Thank you so much, everybody.
Yeah.
Yeah.
No, I just wanted to say that I just really appreciate the folks, Peter and other colleagues from the Access to Medicines movement kind of coming together on this. I'm coming from my very medical technical kind of side. But yeah, thanks very much for everybody coming today, because I think we really need to get more people involved in the diabetes discussion, not only on these new drugs, but on access to insulin, which is not in any way solved. So yeah, really appreciate your time and interest today. And we'll be in touch if that's okay. Just to people who are putting in the chat out the recordings and the slides, we will post on the MSF Access Campaign diabetes webpage, and we'll probably also be able to email them out to you if that's okay with you all. And we will definitely be in touch. And please reach out to us if you have ideas of pieces of work that's going to help move this forward in terms of making sure people in lower middle income countries don't miss out on these really important medicines. Thank you.